Hello, Dr.
Hello.
Rajashri.
Yeah.
Yeah, ma'am. You're live. You can start your presentation.
Okay.
Yeah, thank you so much.
Hi. Good afternoon, friends. I'm Dr. Rajashri Kelkar. I'm Honorary Assistant Professor of Surgery at Grant Medical College and Sir JJ Group of Hospitals, from where I have done my own education. I'm a consultant breast and general surgeon at Saifee Hospital and Shushusha Hospital, Mumbai. About 6 weeks ago, I presented a webinar on breast cancer and breast oncoplasty, and I sincerely thank you all for a great applause. So today it gives me a lot of encouragement to present another webinar on benign breast diseases. So I'll start my presentation. As I have mentioned last time, we'll just quickly go through the breast anatomy. Breast is a dynamic organ. It is continuously undergoing changes from birth towards menopause. Undergoes changes every monthly as well, and according to your age also. It's a modified sweat gland and it contains two types of tissues. The fibroglandular tissue, this is the glandular tissue, and this is the stromal tissue. The stromal tissue is mainly the adipose tissue and fibrous tissue. The blood supply, I'm just emphasizing again, it's a main two arteries. One is internal thoracic, that is we call as internal mammary artery, and the lateral thoracic artery. Also, numerous intercostal arteries also play a role in the blood supply of the breast. The lymph node mainly drain into the axillary lymph nodes. Only 15% of the lymph is drained to the internal mammary nodes of the breast. Now we come to the breast development. So at birth, the girl and the boy have same breast. There are no breast tissue at all. As you can see, there's hardly any breast tissue. Thus, as you grow, the breast tissue starts to increase in size and shape. And at puberty, the breast actually starts looking like a female breast. Sometimes it happens that even a male child can have this type of development. But the real breast development takes place at the time of pregnancy and lactation, when there is complete proliferation and differentiation into breast ducts, lobules, etc. So during this developmental times, we see a lot of congenital anomalies. I'm sure you all have seen this picture, what we call as milk line or a mammary ridge. In humans, as we are higher animals, we see only one pair of breasts which is developed, and all these breasts eventually, they're not developed actually. But sometimes you see numerous nipples, multiple breasts, numerous nipple areola complexes, and so on, as you can commonly see in dogs and cats who have multiple pairs of breasts. So let us see some interesting congenital anomalies. Here, as you have seen, amasia and polymasia, it's only the nipple which is developed, nipple and areola complex. There's absolutely no breast tissue. And the left side breast is absolutely normal. So there are multiple of these amasia and polymasia films you can see. This is my own patient, very young, about 18 years of age. You can see the right breast fully developed with good nipple areola complex. Whereas on the left side, you can only see the nipple areola complex and there is absence of the breast tissue. Absolutely no breast tissue. So this breast is not going to be good for any lactation. These pictures are courtesy of my colleague, Dr. Aditi Agarwal, and I thank her for that. If you can see, there are two pairs of breasts. This is the first normal pair, and if you can see the breasts over into the armpits, you see many a times the armpit breast develop, but there is no nipple areola. Here you can see the nipples very well on both the sides. And she had milk coming out of these nipples during her lactation as well. So it's a very interesting case. Now see supernumerary nipples. On this patient, you can see only the nipple, which is accessory nipple, but there is no areola. And in this patient, there is a nipple and the areola as well. This is a polymastia. For this, supernumerary nipples, amastia, and multiple breasts, we actually won first prize in poster presentation in one of the Massicons. To be precise, Massicon 2019 at Aurangabad. This is polymastia. This is another interesting picture you can see. This is called as tuberous breast. The breast shape is very sort of not a normal breast shape, which is one breast on this side looks very much like a tubule. So that is why it is called as a tuberous breast. And you can see on both the sides, nipple and areola absolutely protruding outside. So let us see when these changes take place. What are the age groups? As you can see here, the fibroadenomas are the breast lumps, benign breast lumps of a younger age group, and they peak at about in 20s and they involute at about 40, 50 years of age. Then they are not seen. So the common age group is 15 to 30 years. Then the cysts you see during the perimenopausal period, that is between 40 and 50 years of age, versus the benign nodularity, what we call as fibrocystic breast change, is seen throughout the reproductive age group. And as you age, the chances of the cancer increase. Now, I'm sure all of you have come across many, many young patients, especially in the reproductive age group, who come up with breast pains or multiple breast lumps and nipple discharge. So these are the common symptoms, or rather commonest symptoms with which the patients will come to you. So we will go and see the pathologies according to the symptoms. So in breast pain, the reasons are many, variety of reasons you can see because of which the patients can feel the breast pain. So mainly there are hormonal changes and there are actual pathological reasons for the breast pain. Now let us see. Now, what are the causes of physiological changes that is due to the hormonal changes? Like you all know premenstrual cycle, premenstrual symptoms, where the patient gets a lot of severe breast pain, pain in the around the hips, heaviness. All these symptoms are called as premenstrual syndrome. Then at the time of puberty, when the breasts are just starting to develop, one can get a lot of breast pain. During pregnancy and lactation, the breasts are again proliferating and preparing themselves for lactation. So you get a breast pain, and in lactation, you can really get severe breast pain when you're feeding on one side and the other side breast literally feels like somebody squeezing that breast. You get that kind of breast pain. And during menopause, rather perimenopausal time, when you get these breast pains. But these are absolutely hormonal breast pains or physiological breast pains, and one is not needed to do absolutely anything about this kind of breast pains. It is only the reassurance which will settle these pains, or it is only temporary, and the pain will settle once the hormonal changes settle. Now, what are the causes or pathological causes of breast pain? Number one is mastitis, any sort of inflammation or infection. Most of the times it is called as mastalgia also. That is only the pain. You don't see any pathologies inside the breast like lumps or nipple discharges or any actual acute inflammation, but the breasts are very tender. Then it is fibrocystic breast disease. We'll come to that. The third one is injury. Any injury to the breast causes a lot of bleeding inside the breast, because the breast is a very soft organ. Bleeding takes place very easily, and that can lead to a lot of pain. And last but not the least is alcoholism with liver damage, as we all know, can lead to formation of gynecomastia also, and it gives a lot of breast pain. Now, how do we see, or how do we ask the patients what are the exact symptoms to come to some conclusions? So there are cyclical breast pain and non-cyclical breast pain. Cyclical breast pain is typically because of the hormonal changes, and it happens premenstrually. That is also called as the luteal phase of the menstrual cycle. It is diffuse, it is dull aching, it is in both the breasts. And patients will give you the history that the pain is more on touch. So otherwise, while sitting down, they don't get this breast pain, but the pain is more only on touch. Whereas in non-cyclical breast pain, most of the time the breast pain is not because of the breast actually. The breast pain may be because of the muscular pain, pain of pectoralis major muscle, or the radiating pain of the shoulder joints, or the chest wall pain. It is classically called as the chest wall pain. So how do you go about it to confirm whether it is a cyclical breast pain or a non-cyclical breast pain? When you examine the patient, you will know whether the breasts are tender or the surrounding area, the musculature is tender, the shoulder movements are tender. You can confirm this with a simple imaging of ultrasound. And once the ultrasound rules out any pathologies actually in the breast, you can easily give reassurance to the patient. For some few days, prescribe NSAIDs or normal painkillers. Evening primrose oil has been mentioned a lot in breast pain, but it has been shown that it doesn't actually play any role in breast pain, but it just acts as a placebo. But in my practice of last almost 20 years, I have found that if you give evening primrose oil over a period of 3 months, almost 80% of patients have absolutely fantastic results and they don't come back. You may add vitamin E oil to it, but in about only 5 to 10% of patients, I have added danazol to it when their pain did not settle. And the non-cyclical breast pain will also respond to your reassurance, some shoulder movement exercises, some exercises to the pectoralis major, and hot water fermentation and things like that. So the breast pain, I'm sure everybody must be getting patients of breast pain, and it is very difficult to treat them if their breast pain is prolonged. You can start on evening primrose oil, give 1000 milligrams of evening primrose oil straight for 3 months, and most of the patients will definitely improve with that. The investigations is only ultrasound. No mammography is necessary. Mammography you do only in patients above 40 years on your clinical examination if you suspect something is wrong or some abnormal findings you see, and if there's a strong family history. But otherwise, only ultrasound for breast pain is good enough, and you can reassure the patients. So the treatment is reassurance. Breast support is extremely important, because if a woman has a very huge sized breast or a large breast, the size of the breast itself causes the breast to hang, and this can increase their pain. So always ask them to have a good, well supported bra. You can ask them to wear sports bra as well, which will reduce the pain. And the literature mentions that the reduction in amount of coffee what they are taking or chocolates can certainly reduce the pain. Reduce the salt intake so that the water retention during the premenstrual uh, duration is definitely less, and the breast pain is also less because of that. And the medication is evening primrose oil and danazol, but use danazol with caution, because danazol can give rise to a lot of irregularity of their menses. So this is all about breast pain. The mainstay for me at least have been medication, evening primrose oil, and sometimes I add vitamin E oil, although both of them act as just placebos. Now we come to another most important things, breast lumps. Most of the times patients will come to you with breast lumps after the symptom of breast pain. Whenever there is a pain, they will rush to you. The next symptoms is breast lumps. Now again, there are many causes of the hormonal changes due to which you see breast lumps. Then we see the common breast lumps and other types of breast lumps. We will discuss one by one. So when do we see the hormonal changes? in infants. Many a times when the babies are born, you will see that both the breasts or one of the breasts is slightly enlarged. And then we wonder, are this baby has a well developed breast or the developing breast? But you don't have to worry about it. This is mainly because of the mother's hormones which have gone into the infant and led to the development of the breast. It is very mild, it is just subtle, but there is no need to worry. As the baby is out of the woman's body, the changes of the hormones will subside and the baby, the development will just resolve itself. Then the young breast buds. Young breast buds are seen in females as well as adolescent age group boys. Okay. Unfortunately, I have seen couple of young girls with the development just about to start, and their breasts were, the developing breast buds as we call it as, were very painful, and somebody had operated that and removed those breast buds, thinking that these lumps are pathological. So my sincere request to all my colleagues is, if you see and feel any lumps in the adolescent, especially females, please do not do anything. Just reassure the child, and you can give them hot water fermentation or cold compresses, start them on vitamin E or evening primrose oil. But please do not operate this. The two young girls who I know have unfortunately no breasts at all, because the developing breast buds were completely removed, and poor kids are left with no breast development. So we have to be very careful when such patients come to us with severe breast pain or complaints of breast lump. And as I said, it can be seen in teenage boys also. As their testosterone hormone settles, this gynecomastia types of symptoms will settle, and we really don't have to do anything. If the gynecomastia persists beyond the age of 20-25, then only you can consider, after doing proper investigations, whether the man needs any surgery for the particular gynecomastia. So these are the hormonal changes when you will see the breast lumps. But mind you, again, these are physiological changes and they settle on their own. Now we come to the common breast lumps. And as you all have seen, fibroadenomas, fibrocystic breast disease, and the cysts are the most commonly seen breast lumps in my practice and in all your practice as well. So let us see one by one. Fibroadenomas are the lumps which are seen in the age group of 15 to 30. Generally, they do not start after the age of 30, but can grow up to the age of 30. You will see a solitary fibroadenoma or multiple fibroadenomas. That they can be unilateral or they can be bilateral. Sometimes these fibroadenomas grow huge, more than 4 to 5 centimeters. I have operated fibroadenomas more than 8 centimeters also. This is the picture. This is the picture of one of my patients. Unfortunately, I have not shown the size, but it was almost 10 centimeters in its maximum diameter. So it can be labeled as giant fibroadenomas. So the natural history is that they grow up to the age of 30, and sometimes in pregnancy they can completely resolve and disappear, or during the perimenopausal time they completely disappear, and there is no risk of any malignancies developing within the fibroadenomas. But most of the patients in India are anxious about it and want these lumps to be removed. So you can go ahead and remove the lumps. Only thing is, if you feel that the fibroadenoma is really big, then I would definitely suggest that you should do a core biopsy, make sure that it is a fibroadenoma, and then only plan for its excision, because many a times fibroadenomas and the phylloid tumors can look the same even on histopathology, because both the lumps are called as fibroepithelial tumors, like they have glandular components as well as fibrous components in them. And when you're dealing with huge, large tumors, I think you should do a core biopsy to make sure that they are only fibroadenomas and not phyloid tumors. But mind you, I have got experience with when I've operated them after doing a core and confirmed with fibroadenoma, and the final histological diagnosis was phyloid tumor. And my patient was actually ready to sue that pathological lab. But it is said that unless until you submit the whole specimen of the fibroadenoma, it may be difficult for even the pathologist to say that whether it's a fibroadenoma or a phyloid tumor. So be a little careful when you are excising huge fibroadenomas. Take care that the aesthetics are preserved. You can use subareolar incisions or inframammary incisions to remove these giant fibroadenomas. They look, on clinical examination, these fibroadenomas are called as breast mouse because they are very well circumscribed and they slip below your fingers. And I'm sure all of you have experienced and seen many patients of fibroadenomas. I don't have to go into these details. I just want to specify one thing. In this picture, as you can see, this is a multilobulated fibroadenoma. There are many, it looks like there were many fibroadenomas which have conglomerate and form this huge lump. If the fibroadenoma shows on ultrasound there are more than 4 lobulations, then I think you should get a biopsy done. That is what the radiological society always recommends, that more than 4 lobulations, the biopsy should be done to rule out that there is nothing else but only a fibroadenoma or a phyloid tumor. It looks a very homogeneous structure on an ultrasound. Ultrasound is the only investigation necessary to confirm your clinical diagnosis of fibroadenoma. So fibroadenoma is mainly a clinical diagnosis, but you can confirm with ultrasound, especially if patient has multiple fibroadenomas or bilateral fibroadenomas. So you will know possibly there are very tiny fibroadenomas also along with the one which you are palpating. So you can definitely tell the patients that there are some few more tiny fibroadenomas which you don't have to remove if they are not palpable. Now we come to another very challenging pathology, which is called as fibrocystic breast change. When I was young and studying at that time, it was called as fibrocystic breast disease. But now it is seen that almost 50 to 60% of women in a reproductive age group can see this fibrocystic breast change almost all over the world. And that is why that breast disease, fibrocystic breast disease term has been taken down and it is labeled as fibrocystic breast change. Where a patient comes to you with the swelling of the breast, pain in the breast, which is non-cyclical, or some areas of the breast where is only thickening or lumps formation, and patients can complain of various colored discharges. The colors can vary from black discharge to brown discharge to greenish kind of discharge as well. So the lumps can be of a size of granules to peanut sized lumps or large lumps, but the whole breast will feel like a lumpy breast. And this pain increases premenstrually, but it does not settle after the periods are over. So it fluctuates in size. It is not sure. Sometimes the nipple discharge is there, not every time. But your ultrasound will give you a correct diagnosis. And the pathology, what you do see is there is adenosis, apocrine metaplasia, fibrosis, ductectasia, mild ductal hyperplasia, and as the name says, fibrosis and the cystic changes both are there in fibrocystic change. So in fact, fibrosis and the cystic changes are the dominant changes which you see in fibrocystic change. And the risk factors are Whenever a patient has a dense breast or sclerosing adenosis, atypical ductal or papillary lesions, or a lobular hyperplasia. When a patient has a fibrocystic breast change, it slightly increases her chance of getting malignancy at a later age. It's predicted about 5% of women may be at higher risk of getting malignancy in these patients who have got fibrocystic breast change. Again, ultrasound, mammogram, and biopsy are definitive investigations. I would say that mammogram also may not be necessary if the patient is less than 40 years of age. Ultrasound will give you the diagnosis of fibrocystic breast change. If there is a definitive lump which you're not sure what it is, then I would definitely recommend you to do a core biopsy and confirm the diagnosis. But once you're sure that this is only the fibrocystic breast change, there is probably no indication for surgery. I have had one patient who had almost uh, 10 scars on her breast from various areas. These lumpy areas were surgically removed, and she still continued to get this pain continuously when she saw me. And every time in every excision biopsy, the fibrocystic disease was like highlighted. So once you diagnose the patient with fibrocystic breast change, there is no need for surgery. You can manage the patient on medication. Again, the same NSAIDs, gamma linolenic acid, that is the extract of evening primrose oil, which you can use. Avoid caffeine, chocolates, reduce the salt in intake. And sometimes the OC pills also will work very well, because fibrocystic breast change, many kinds of breast pain are due to irregular periods, or they are seen more in patients who have got PCODs. And it is purely because of hormonal changes. Their hormonal cycle is not correct, or it is not a monthly cycle. So they do get all these fibrocystic type of changes or breast pains. So you can prescribe OC pills for women who do not get regular periods. With regularization of their periods, their breast symptoms will definitely reduce. Now we come to another most important breast lump, which you will see during a perimenopausal age group, and that is called as breast cysts. For my non-medical friends, let me explain that these breast cysts are nothing but fluid-filled balloon kind of masses. So there's clear fluid inside them. And if you do a sonography of perimenopausal age group women, that means the sonography of women above the age of 40, you will see that probably every woman has some sort of breast cysts of various sizes and various shapes. Generally, we do not need to do anything about this breast cyst, and they will resolve on its own. In fact, patients don't understand when they are developing the cyst and when they are not, because they are really tiny. They are most of the times in few millimeters. In very few patients, this cyst become enlarged and they can feel it as a lump, and only then the patients will come to you with the complaints of breast lump. They can be on one side, they can be on both the sides, they can be single, or they can be multiple. But the multiple breast cysts are the norms, what I would say. They pathologically, they are into the involution phase. The glands which are there in the breast to produce milk during perimenopausal age group, when they are completely involuting, during that phase, you can see this cystic formations. If the cysts are clear, but they are big in size, patients can feel it as a lump. You can just aspirate the cyst fluid with a 18 number needle. And it is actually like a magic to the patient, because the patient comes with a breast lump. which has grown probably over last 24 to 48 hours, which I have seen numerous such patients. The size of the cyst has suddenly grown, and you put in a needle, aspirate the fluid, which is straw colored or which is brownish in color or which is serosanguinous in color, and a lump resolves or disappears completely immediately. And there is no need to operate on breast cyst unless the cyst is chronic and the cyst wall is very thickened. In that case, if the repeated aspirations do not suffice your treatment and the breast cyst is refilling again and again, then only there is any indication for surgery. But a simple cyst, there is absolutely no indication for surgery. Just put in a 18 number needle, aspirate the cysts. If there is any blood tinged fluid, then definitely send it for cytology. But otherwise, a clear cystic fluid, you do not even have to send it for cytology. Rarely blood stained fluid. Now, I would want to warn you on one topic that sometimes the cysts are labeled on sonography as complex cysts. That means there is a cystic area and there is a solid area within this complex cyst. If you have a patient who has a solid component also in her complex cyst, then please send the patient for ultrasound guided biopsy of this solid component. It is extremely important because if you aspirate the liquid component of it, then the ultrasonologist is not able to see the solid component, and then they cannot biopsy. I have recently had a patient who had a lump since last 4 to 5 years, but suddenly grew to size of 8 to 9 centimeters over last one month. On ultrasound, it showed that along with the cystic area, there was a big solid component in it as well. So I sent her for ultrasound guided biopsy, and the biopsy has shown this to be intracystic papilloma. Now, when we operate and send the whole specimen for histopathology, then only we will come to know whether this is a very rare form of intracystic papillocarcinoma or this is a benign cystic papilloma. So whenever you see a complex cyst with a definitive solid component in it, please do send the patient for ultrasound guided core biopsy. There is no role of doing FNAC on this. Now, other lumps are breast cancer, which we have discussed last time. Galactocele is a very specific, and breast abscesses more for the pregnancy and lactation. We will discuss that. Intraductal papilloma is another important and frequently seen lump. Injury or hematoma, we have just talked about it, that whenever there is an injury, there can be bleeding, and after say about 8 days, the patient can feel it as a lump, and that is a hematoma that can give rise to fat necrosis, which is a solid lump, which mostly resolves on its own. But if it is not resolving, you can take it as it is a fat necrosis and you can excise that. And we'll discuss the phylloids tumor in details as well. Now, this galactocele is classically seen obviously during lactation. It is a painless lump, totally painless. When the patient is breastfeeding, she comes up with a lump, and you can be rest assured that it is most likely to be a galactocele. Even if you do not have the facilities to do ultrasound immediately, just put in a 18 number needle and aspirate. Again, just like cyst, any simple cyst, once you aspirate the milk, this lump will completely dissolve, and it's absolute magic to the patient. It's a very simple thing to do. It is painful only if it is infected. So have a very low threshold of doing ultrasound on all lactating women. We'll come to all those things when we come to lactation. But whenever there is a globular cyst, globular lump in a lactating female, put in a needle. If you want to do ultrasound before that, you can do ultrasound, confirm your diagnosis of galactosile, just put in a needle and aspirate. In case if it is infected galactosile, send the patient, send the pus for culture sensitivity, and you can start the antibiotics according to culture sensitivity. Always, 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 whenever you have inflammatory or infective pathologies in the breast, try and aspirate the pus and send it for culture sensitivity. Because many a times I have seen these breast abscesses, which are typically MRSA, methicillin resistant Staphylococcus aureus, and they are not sensitive to amoxiclav and the routine antibiotics what we use. They are sensitive only to linezolid, and to your surprise, you will be surprised to know that they are very sensitive to even doxycycline. So please send that for culture sensitivity and start antibiotics only after you get the culture sensitivity report. Intraductal papilloma. How does a patient will come to you? Patient comes to you with blood stained nipple discharge. Now there's this duct, particular duct, which I have shown here. You can see a classical filling defect in this duct. There are numerous defects actually, and you can see a red core in this, which is causing the bleeding into the duct, and this duct drains onto the nipple and causes the blood discharge. If you send this blood stained nipple discharge for cytology, many a times they will show ductal papilloma cells, and your ultrasound will confirm that this is a ductal papilloma cell seen in that, or a duct papilloma seen. Microdocectomy is the treatment. How do you do a microdocectomy? I have shown it here. This is the nipple. You can see a 3,0-ethylon, which I have cannulated the duct. The 3,0-ethylon goes like this because you cannot see the duct, and which has been described as a tennis racket incision. So you take the small incision over the nipple and areola and a larger incision. The usually these papillomas are within first 2 to 3 centimeters of the duct. So you remove up from the nipple, you remove about 5 to 6 centimeters of the duct completely. So here you can see the threaded duct, and you can see that nipple, the thread going into this duct. Feel the duct, feel the thread, and go down and excise this complete area from where you are getting the nipple discharge. This is called as microdocectomy, where you are removing the duct which has the papilloma in it and sending it for histopathology. Hematoma we have discussed in detail. Ultrasound tells you exactly if it is a clear cyst or it is a hematoma, because there will be a definitive solid component in it, which is the blood clot. So again, if it forms an abscess, you may have to drain it, or you can just aspirate with 18 number needle. Now we come to something called as phylloides tumors, which are of 3 types, which can be a benign phylloids, which can be a borderline tumor, and malignant phylloids as well. Malignant phylloids spread to the body via bloodstream. So they have hematologic blood spread. So you can see this patient with a huge tumor and her mammography showing the tumor, which is homogeneous, but at places it is not very regular in shape, and it is occupying almost the full breast. In such a patient, you will have to do a simple mastectomy, but in phylloides, there is no need to do any axillary sampling. Another huge phylloids, the nipple and areola has shifted over here. The lower portion of the breast has increased. Unfortunately, I do not have her mammography report. See the size of this mass after excising. It's almost 17 to 18 centimeters in size. Huge tumor. This was our star patient. This lump grew over a period of 7 years. She had seen somebody about a year ago before this picture was seen. Core biopsy was done, phylloid tumor was diagnosed, but for some or the other reason, she did not show up at any medical facilities and came to me like this, where you can see the skin is breached and it is popping out completely. See, this was the tumor when I had first seen. Again, she took about a month to come, and you can see from this skin defect, the lump, the phylloid tumor is actually popping out. Can you see the weight? It is almost more than 4 kilos. I'm sorry, this was operated in JJ Hospital. We did not have a proper weighing scale for such a huge tumor, almost 5 kilos. So we have used the patient scale to see, and you can see this is a 5 kilos mark, and this is a 10 kilos mark, and this is more than 4.5 kgs in size. So you imagine this patient was carrying this huge tumor. You can compare the other side of the breast and you will have the idea what is the size of this tumor. But fortunately we could get along the edges and close it primarily because it had a stalk. The tumor was going down, and from the base of the breast it was proliferating out. We could easily close it primarily. So it is mostly benign, but it spreads via the bloodstream. They can mimic larger fibroadenomas, usually seen after the age of 40, but I have seen phylloides tumors at a very young age also. If it is a big tumor, always do a true cut biopsy. If on true cut biopsy you get the diagnosis of phylloides tumor, then you definitely do a wide local excision and not a enucleation like what we do it and do it in a fibroadenoma. Recurrence is only seen if the tumor is not removed completely, but I have myself had patients, now 2 patients who have had recurrence of phylloids in the vicinity of the previously operated bed, now for the 3rd time. Right now I have this patient who has developed it for the 3rd time. Another interesting and absolutely uncommon and rare tumor, which is called as hamartoma. You can see this patient. This was a 36-year-old patient with a huge left side breast, macromastia. There was a definitive, I can show you her mammogram. See her mammogram, again filled with full breast, almost filled with this well circumscribed, well defined tumor. I did her core biopsy, which showed a hematoma, but the pathologist told me that we cannot make out what this tumor is. Please submit the tumor completely in toto. So we excised this tumor, did a wide local excision, but this is the actual specimen. It was almost 15 centimeters in size, completely excised. This is almost now 5 years down the line, and patient is fine. Just to give you a little bit information about the hamartomas. Hamartomas are a very rare tumors which are developed from the native tissue only, and there can be some element which is abnormal in amount, and this hamartoma was myeloid hamartoma, what they have described as, which means it had a smooth muscle component in it. We did a complete literature search, and very few huge sized hamartomas have been put it in the literature, and this was one of the biggest hamartomas which I have published. Whatever pictures I have shown you so far, they all have been published in reputed journals. There is a immunohistopathological correlation is required for these rare tumors such as hematomas to confirm the diagnosis of smooth muscle involvement in it. So the mean tumor size of this hematoma, this is the literature study which is showing mean tumor size was 3.9 centimeters in about 27 patients. Our patient had 15 centimeters. So this was one of very few hematomas which was reported. Now we come to nipple discharge. Again, there are hormonal changes and other causes which we have almost discussed. You see milky discharge during lactation, pregnancy, hyperprolactinemia, which is also called as galactorrhea, or pituitary micro and microadenomas. The treatment is very simple. You can give bromocriptine and it stops. Now, serous discharge. Many a times patients will come to you with serous discharge with no underlying pathology. You do a sonomammography, you do a mammography, there is absolutely nothing. And it is seen in all the para patients who have born children in mid-cycle, they can have clear discharge and there is no pathology associated with it, and you do not have to do anything about that. I was talking about black, brown, and greenish discharges, which are typical of ductectasia or fibrocystic breast changes. What we need to be aware mostly of is blood-stained nipple discharge. And there are three most common causes of blood-stained nipple discharge. One is obviously breast cancer, second is intraductal papilloma, and third is ductal ectasia. So if any of these, once you see the blood-stained nipple discharge, you can send the discharge for cytology, but please send the patient for sonomammography and mammography and see what is the underlying pathology, and we need to deal with that. Again, the hormonal changes can lead to nipple discharges. During menstruation, you can have nipple discharges and lactation. Ductectasia, breast cancer, we all have discussed it just now. Now we come to pregnancy-related breast problems. During pregnancy, mindfully and physically, we need to get used to the idea that breastfeeding needs to be done for the sake of the baby and for the sake of the mother as well. And the right way to do breastfeeding is not shown or not taught to a young mother. And that is how you deal with these problems of mastitis and breast abscesses. So here I have shown you one hypothesis is that after the feeding, we wipe the mouth of the baby with cotton or a wet cloth and we rub it. This causes microabrasions in a very tender mucosa of the infant's mouth. And these abrasions can harbor Staphylococcus aureus, which is a native to the mouth. It doesn't cause any pathological changes to the baby. But if the mother has cracked nipples, then the Staphylococcus aureus through these cracked nipples travel into these ducts and go up into the lobules where the milk is produced. Now, as you all aware, the milk has human milk has lot of sugar in it, and these bacteria thrive upon this sugar and cause a infection. Here you can see a inflamed globule. And let me tell you, all our mothers and mother-in-laws will tell you that if you have a pain during breastfeeding, do hot water fermentation, put a lot of hot water so that the milk flow will be good and all. It is not right. If you have a lot of pain while you are breastfeeding and your breast is tender, then please do not do any hot water fermentation. You are actually ripening the infection. Instead, always use a ice compresses or cold packs. If you see any patients complaining, this is for all my gynecologist friends, if you see any patients during their lactation complaining of breast pain, keep your threshold for doing ultrasound very low. Having a redness on the top of the breast is a late sign of diagnosing a breast abscess, and you should find out a infection in the breast at the stage of mastitis only, and you should not allow the pus formation to take place. Whenever there is inflammation in a lactating breast, please start off antibiotics. The first thing what I want you to do is do an ultrasound, make sure that there is no pus formation and start the patient on antibiotics. If there is pus formation, then the patient will not improve unless and until the pus is drained. Now, if there is a small cavity, you can again put in a 18 number needle, aspirate the pus, send the pus for culture sensitivity and treat the patient with repeated aspirations and antibiotic therapy. Avoid a lactating breast to be incised for incision and drainage. Also, I request you not to stop the lactation. Many of my own colleagues stop the lactation, but I feel it is unfair for the baby to stop the lactation in a hope that the breast wound which you have incised for and done incision and drainage will heal faster if there is no milk formation. But I feel the breastfeeding should be continue if the infected milk is not going to the baby. And how do you know that the infected milk is not going to the baby? If the infected milk is going to the baby, then the baby will have frothy diarrhea kind of stools. If that is happening, then avoid that side of breastfeeding. You can continue from the other side to breastfeed without absolutely any problems. And whenever there is pus, try to do repeated aspirations. If need be, do it under ultrasound guidance with a nice big needle of 18 number. Keep on aspirating pus, and that is the way to go ahead. If you need to do incision and drainage, that means you have diagnosed the breast abscess at a very late stage. When you do incision and drainage, you are distorting the architecture of the breast. And in that area, for the next pregnancy, the milk and milk supply to the baby will not be there. So please keep your threshold low for doing ultrasound. It's a very simple test, very accessible and easily acceptable, non-invasive. Please keep doing ultrasounds whenever a lactating woman complains of breast pain. So mastitis in a lactating woman is a clinical diagnosis. You can confirm, you only need an ultrasound to see whether there is a pus formation already happened or no. If there is no pus formation, just start her on antibiotics and complete it. Again, let me make you aware that most of the times what infections I see in breast abscesses are MRSA. So please start on the drug linezolid or simple doxycycline. Co-amoxiclav is not been seen to work. Ultrasound will show the presence of pus. Now I'll show you what I have done. This was the initially pointing abscess, which you can see the redness all around. I kept on aspirating and you see the result here. You can see the skin almost healing. This patient, I gave the antibiotics for about 2 weeks and she's completely resolved. I did not have to do any incision and drainage. So the treatment is antibiotic, continue to breastfeed, keep on calling her up every 48 to 72 hours to do the aspiration of the pus. Once only send the pus for culture sensitivity. Definitely send the pus for culture sensitivity and start the antibiotics accordingly. This was the disaster which I came across in 2015. This was a lactating woman. This is why I have shown you the picture. Lactating woman had a breast abscess. See the incision which was done somewhere else, and a non-dependent. You can see that the patient's head end is here and the tail end is here. Non-dependent drainage, and you can see the slough. The incision actually caused this to happen. There was fulminant skin infection, and within 48 hours of this incision, the patient came to me with this gangrene, absolutely gangrene breast. This was her residual effect. The full breast was gangrenous. There was pus filled all over the breast cavity. It was like a bag of pus actually. And this was her first pregnancy. This is what the residual is. We could not close it. We kept it open, applied a vac dressing for almost for 15 days, and then we closed the wound. So she almost had the partial mastectomy for this only infective procedure. And I think this has to be avoided at any cost. So lactating infections can spurt within 48 hours or 24 hours also. So be vigilant and be very proactive in treating these with antibiotics. So teach how to breastfeed. Apply vitamin E oil between the breastfeed. If there is a cracked nipples, don't ask the patient to feed from that side for 48 hours. Keep applying vitamin E oil till the cracks heal, and then she can resume the breastfeeding again. But she can continue the breastfeeding from the opposite side. No heat, please. If there is any signs of any inflammation in the feeding breast, lactating breast, then the choice is to give cold compresses or ice packs. Now we come to one important thing called as chronic granulomatous mastitis. All my colleagues who are doing breast surgery will come across this. Chronic granulomatous mastitis is a chronic inflammatory condition of the breast. There you see the chronic recurrent breast abscesses that mimics tuberculosis, but it is not a TB origin, but you still see the granulomas in a histopathology. That is why the name granulomatous mastitis. So if you come across any patient who has got the recurrent breast abscess, when you do the incision and drainage, kindly send the tissue for histopathology, which might show you chronic granulomatous change. And it is in the absence of any trauma, any evidence of sarcoidosis, and things like that. The treatment of choice has been discussed as steroids, antibiotics, abscess drainage, and wide surgical resection, and even sometimes mastectomy. Thank God I have never done a mastectomy from chronic granulomatous mastitis, but I have done wide surgical excisions, and which has stopped the recurrence of the abscesses. Now there have been many papers, but the paper, the reference which I have put it over here, clearly shows that at least in this paper, there is no role of steroids in chronic granulomatous mastitis. I have successfully treated chronic granulomatous mastitis by giving the patient 6 weeks of linezolid. Many a times they come to back to us with pus formation. Till that time, you prescribe again linezolid. But many of my colleagues do use corticosteroids. So I'm not going into depths and details of chronic granulomatous mastitis because the treatment is absolutely controversial, and whether to give along with antibiotic corticosteroids or no, it's individual choice and what is the experience of individual surgeon. But just to keeping in mind that if the patient comes to you with recurrent breast abscess, kindly do histopathology on the tissue over there. So with this, I think I have covered most of the benign breast problems. Thank you very much for the patient listening. And I will conclude my talk and thank all of you with my photo of my FRCS convocation, which was way back in 1998. Thank you very much. It has been a pleasure and a great journey with you all. The webinar, which I had about 6 weeks back, and this webinar on benign breast diseases. Thank you very much. And I sincerely thank Librate also for giving me this chance to present my work. Thank you, Librate.
Yeah, thank you so much, Dr. Rajashri Kelkar. It was an insightful session, ma'am. Thank you for sharing this. And I thank you on behalf of all the doctors and audience who joined today and from Librate. And we look forward to host you again in future, ma'am. Thank you so much for your time.
Thank you, Ram. Yeah. Thanks.